Greetings everybody. Today's class is about body fluid compartments and I am your teacher Dr. Mudassir Mirza, Assistant Professor of Physiology. Now, it's a well-known fact that the maintenance of relative constancy of the volume and a stable composition of body fluids is very essential for the maintenance of homeostasis. What is homeostasis? The internal constancy of internal environment around the each and every cell. Most of the common problems in clinical medicine arise because of the abnormalities in the control systems that maintain this constancy of body fluids. That is why it is very important to learn what are these body fluids, what is its composition, what are their subdivisions, how are the body fluids redistributed in our body. So in my today's class, I'll be discussing about the different components of body fluids. Then how are they measured? Then how are they maintained constant? And what are the different abnormalities of this fluid balance? So let us begin. First and foremost, this is a graphic showing the total body water. Total body water in an adult male, it is about 60% of his body weight. Now this total body water is divided into several compartments. There are two main compartments. One component of body fluid is present inside the cell, which is called as intracellular fluid. And the other component of the body water, which is present outside the cell, is called as extracellular body fluid. Now, this extracellular body fluid is again divided into four other subtypes. I'll be discussing later. Now, on the left hand side of this slide, you can see there are absolute values of intracellular fluid, extracellular fluid given in liters. These are the approximate values seen in a 70 kilogram adult male. But it would be apt if we remember the body water content in terms of percentage of body weight. That's why I have taken this graphic in which we can see the intracellular fluid is about 40% of total body weight. Now, let me remind you that total body water is only about 60% of body weight in an adult male, and it is about 50% of body weight in an adult female. Out of this 60%, 40%, the major component, goes to intracellular fluid, the fluid which is present inside the cell. So it is about 40%. Remaining 20% of extracellular fluid is divided into four subtypes. One of the major subtype is the interstitial fluid. This fluid is present around the tissues, which accounts to 15% of total body weight. Next is the blood plasma. This blood plasma is present in the blood vessels. Red color blood vessels, what we see in that, the blood plasma accounts to a subcomponent of extracellular fluid, which is only 5% of total body weight. Another component of extracellular fluid which is not shown here is the mesenchymal tissue fluid. Now, mesenchymal tissues are connective tissues, the cartilage, the bony matrix. In this also a certain amount of fluid is present. That is extracellular fluid is present, which is called as mesenchymal tissue fluid, which accounts to about 6% of body weight. Last but not the least, a small amount of extracellular body fluid is present inside the cavities. These cavities could be cerebrospinal space, it could be lacrimal space, it could be intraocular space, it could be the space between the pleura, space between the pericardial membrane, it could be the space between peritoneum. In all these spaces, whatever fluid is present is the transcellular fluid, which accounts to 1.5% of body weight. So the examples of transcellular fluid are: number one, the peritoneal fluid; number two, pericardial fluid; pleural fluid; lacrimal fluid; cerebrospinal fluid; synovial fluid. So these are the transcellular fluids which account for 1.5% of body weight. So that is about the distribution of body fluid in different compartments. So these are the different compartments in which they are distributed. Now, one more thing you can see here in this graphic, that the plasma and the intestine, the plasma and the interstitial fluid can freely exchange. This exchange is governed by Starling forces. Now, these Starling forces are governed by oncotic pressure and colloid osmotic pressure. Oncotic pressure is due to the pressure due to the osmolality exerted by the plasma proteins, or proteins inside the interstitial fluid, or proteins inside the blood plasma. Whereas colloid osmotic pressure is a pressure exerted by colloid component of the blood plasma or interstitial fluid. Now, another component and the pressure which governs this is hydrostatic pressure. Hydrostatic pressure tries to push the fluid from one component to the other. Like the plasma hydrostatic pressure tries to push the fluid from the plasma into interstitium. Interstitial hydrostatic pressure tries to push the fluid from interstitial fluid into the blood plasma. Whereas oncotic pressure and colloid osmotic pressure, they try to retain or pull the fluid into that compartment. Like interstitial fluid, oncotic pressure tries to pull the fluid into the interstitial fluid compartment, and the plasma oncotic pressure tries to pull the fluid into the plasma. So that is one way in which the fluid exchange between plasma and the interstitial fluid. Another exchange of fluid occurs between intracellular space and the extracellular space. Here only the water exchanges. The electrolytes like sodium and all, they are less permeable relatively. So only the water exchanges between intracellular fluid and extracellular fluid, which occurs mainly between the interstitial fluid and the intracellular fluid space. Okay, so now let us move on to the measurement of body fluid volumes. The method used for measuring the body fluid volumes is indicator dilution method. Here the principle is an indicator substance is injected into the compartment. Example, extracellular space you take or intracellular space. In that space, the indicator substance is injected and the volume of the compartment is measured from accurate measurement of the concentration. After the substance redistributes, its accurate concentration is measured, and amount of substance removed either by excretion or metabolism is measured. After measuring this with the formula V is equal to A1 minus A2 by concentration by C, from there we can calculate the volume of the compartment, where A1 stands amount injected, A2 stands amount excreted, and C stands for concentration of the substance. This is how we measure the different body fluids. The different body fluids which we measure, for them there are specific criteria of an indicator substance. Number one, it should be non-toxic. Number two, it should mix evenly. Then number three, it should be easy to measure. Number four, it should not have any effect on the metabolism inside that compartment. Now, the substances which we use to measure total body water are the radioactive water, that is deuterium oxide and tritium oxide. One of the other third substance which we use for measuring total body water is aminopyrin. The substances used for measurement of ECF are radioactive sodium, radioactive chloride, bromine, sulfate, and thiosulfate. And nowadays we are also using, instead of these radioactive substances, we are using inulin, mannitol, and sucrose, which are relatively non-toxic for measurement of extracellular fluid. And for measurement of plasma, we use radioactive iodine or Evans blue dye. The fluid compartments in which we cannot measure the fluid volume are intracellular fluid volume and interstitial fluid volume. So these are deduced indirectly. So intracellular fluid volume, it is very difficult to measure, as it is very difficult to inject the dye or the measuring substance, indicator substance into each and every cell. So what we do, we measure total body water. From that, we subtract whatever measured value of extracellular fluid we got. So that's how we measure, or we come to the calculation of intracellular fluid. Next, coming to the interstitial fluid. This is also very difficult to measure, but it is measured by measuring ECF, from which the measured plasma volume is subtracted to get an interstitial fluid volume. This is how we measure it. Now, Coming to the constituents of ECF. Here clearly you can say this is the plasma, the outermost uh, component of extracellular fluid. Okay, these two, plasma and interstitial fluid, represent the extracellular fluid, and there is a lot of difference in electrolytes. Even though the osmolality is same, 290 milliosmoles per kg is the osmolality, normal osmolality of our body fluids, which which is constant both in extracellular fluid and intracellular fluid, but the constituents vary. In ECF, you can see ECF and interstitial fluid, you can see the major cation is sodium, whereas minor cation is potassium. Major anion is chloride in plasma and interstitial fluid, and bicarbonate and proteins are minor anions in plasma. There are very less amount of proteins in anion proteins in interstitial fluid. On the contrary, if we see the intracellular fluid, it contains a lot of potassium as a major cation, and uh, uh, conversely, sodium is the minor cation inside the cell. The major anions are phosphates and proteins, anionic proteins, and bicarbonate and chloride are minor cations, minor anions, sorry. And the major anions in ECF are chloride, whereas minor anions in intracellular fluid are chloride. So that is about the constituents. Now coming to the regulation, how it is regulated. Before going to regulation, this topic, as I have stated earlier, we face a lot of clinical problems once there is loss in control or abnormalities in control of maintenance of this body fluid composition. Common problem, common case. A person suffering from diarrhea has come to you. Now you know that person is dehydrated because of excessive loss of fluid. But how much fluid should be replaced? That is another question. For that, you should know how much fluid is intake and how much fluid is output from our body normally, so that we can replace how much output is there or how much our body requires. So normally, in normal situation, we require about 2 liters of water, and about 200 ml of water is generated from metabolism. So total body water requirement per day is 2300 ml, whereas output, which counters the output, the total urine output per day is 1.5 liters. Along with that, we lose some 100 ml in sweating, 100 ml in feces, and insensible loss through lungs, that is expiration, and through skin. So these are the losses. But in prolonged heavy exercise, or when person is severely dehydrated, or if he is suffering from high fever, then a lot of fluid is lost from lungs and sweating. So whatever loss is there, which this we have to cover it by giving extra IV fluids. So you might have seen in several hospitals, IV fluids are given regularly to recover or to overcome the fluid loss, ongoing fluid loss in a person who is suffering from high fever or some ailment or illness. Okay, so this input output chart is very important to understand. Now few points about concept of osmolality. What is osmolality? It is the amount of solute per kilogram of solvent. Here the solute is the electrolytes which is present inside the extracellular fluid, and water is the solvent. It is also called as tonicity. The main ion responsible for osmolality in ECF is sodium. So sodium ion mainly decides the osmolality. So wherever the sodium moves, it along with it drags the water. So that's how it decides the amount of extracellular fluid, by dragging the water wherever it goes. When the sodium concentration increases, amount of ECF increases. When the sodium concentration decreases, amount of ECF also decreases. Okay, so now what is the normal plasma osmolality, or ECF osmolality is 290 milliosmoles per kg body weight. Next, the fluids which have the same osmolality as that of plasma or ECF are called as isotonic. Examples are normal saline, dextrose normal saline, 5% dextrose. These are the solvents which we use commonly for maintaining the normal osmolality of the patients in which we are giving the fluid therapy. The uh, other types of fluids are hypotonic solutions which have osmolality lesser than ECF osmolality. Example is half normal saline or 0.45% normal saline. The fluids which have osmolality higher than ECF osmolality are called as hypertonic solutions. Example is 3% normal saline. Now moving on to, there are two separate and closely interrelated control systems that regulate the volume and osmolality of extracellular fluid. It is very important to regulate extracellular fluid volume to maintain normal blood pressure, which is essential for adequate tissue perfusion and functioning. The body regulates ECF volume by monitoring and adjusting total body content of sodium chloride. And so this volume of ECF is mainly regulated by maintaining the concentration of sodium chloride. Why? Just now I explained. Sodium concentration is the main component of osmolality of extracellular fluid. Wherever the sodium concentration, whenever the sodium concentration increases, it drags a lot of water by osmotic by osmosis and increases the ECF. And vice versa happens when sodium concentration falls. When sodium concentration falls, the solvent or water is dragged away from the ECF. So that's how the ECF volume is regulated by adjusting total body content of sodium chloride. And it is also important to regulate extracellular osmolality. This is another component. The total body osmolality is regulated by because hypotonic and hypertonic osmolalities, they impair the normal functioning of cells, which might compromise the cell functioning. So the body regulates the extracellular osmolality by monitoring and adjusting the total body water content. So these two entities, that is regulation of ECF volume and regulation of osmolality, which are directly related to total body water content, I will be discussing now. The regulation of ECF for proper perfusion and maintenance of total body osmolality by adjusting the total body water content is done. Now what are they? Regulation of total body osmolality is done by adjustment of total body water, that is the defense of tonicity, defense of osmolality or tonicity. Tonicity and osmolality are interrelated terms which I have discussed just now. Then there is regulation of effective circulating volume, which is done by sodium balance or this is also called as defense of extracellular volume or volume defense. Now these two mechanisms and these two control systems, how they operate, let us see. First and foremost, defense of tonicity. The osmolality, total body osmolality is defended by two mechanisms. One is by activating the thirst center, and another is by release of arginine vasopressin hormone, which is also called as antidiuretic hormone. Thirst mechanism increases the water intake and antidiuretic hormone increases the water retention. That's how a lot of total body water is retained and total body water content is increased, which dilutes the extracellular fluid and retains the osmolality or tonicity. How it occurs in detail, in depth, let us see. Whenever there is increase in osmolality, it stimulates the osmoreceptors. It causes the shrinkage of these osmoreceptors. These osmoreceptors are, whenever they are activated, they activate the thirst osmoreceptor or arginine vasopressin osmoreceptors. When the thirst osmoreceptors are activated, They cause the neural activity which informs the subject or person to take more and more water. Example, when we go in a hot sun in summer, now we are having summer in India. So whenever we go out, obviously there's a lot of water loss. In other words, whenever there is water loss, there is increase in electrolytes or increase in concentration of electrolytes, which increases the osmolality of blood. Whenever there is increase in osmolality, obviously in us, what happens is there is stimulation of osmoreceptors. The moment thirst osmoreceptors are stimulated, we feel thirsty in the hot sun. So what we do, we move to nearby water source and drink some water to regain our osmolality. So whatever neural mechanisms required for movement of the organism towards the intake of water, these mechanisms are activated by thirst center. So there is increase in water intake and osmolality is retained, or the defense of osmolality is done. The other mechanism is stimulation of arginine vasopressin osmoreceptors. When this is activated by increased osmolality, AVP neurons release arginine vasopressin, which acts on distal part of nephron. In the distal part of nephron, it causes retention of water. That's why the other name of arginine vasopressin is antidiuretic hormone, ADH. Okay, so this ADH retains a lot of water, or in other words, it prevents the loss of water in urine. It is anti-diuresis. Diuresis is loss of water in urine. So anti to it is antidiuretic hormone, the other name of arginine vasopressin. This is how the water is retained. When the water is retained, obviously the extracellular fluid is diluted and osmolality is brought down to the normal range, that is 290 milliosmoles per kg body weight. So these are the two mechanisms by which tonicity is defined. Next is regulation of ECF volume. The ECF volume is required for proper perfusion of the tissue, for proper maintenance of blood pressure with which the tissue are perfused. Before going to the regulation of ECF volume, we should understand the concept of extracellular effective circulating volume. Now, there is one condition which is called as anaphylactic shock. In this, there is no loss of blood from the body. The blood volume is as normal, that is 5 liters in a normal person, but still the perfusion to the vital organs like brain and heart and kidney is reduced in a person who is suffering from anaphylactic shock. Why it is there? Because the effective circulating volume which is required for normal perfusion of brain, heart, lungs and kidneys, the vital organs, is reduced. So this is not an absolute volume, it's a physiological dynamic volume which is required for effective perfusion of the vital organs. That's how the definition comes. It is the amount or the part of extracellular fluid which is required for proper tissue perfusion of vital organs. The quantity, the relative volume of this effective circulating volume is roughly about 700 ml. Whenever there is fall in effective circulating volume, it activates four mechanisms for regulation of this effective circulating volume. The sensors for this effective circulating volume are carotid sinus, aortic arch, renal afferent arterioles and atria. These are the four. And efferent pathways are also four: the renin angiotensin aldosterone axis, sympathetic nervous system, arginine vasopressin release and atrial natriuretic peptide release. When these four mechanisms are activated, they increase the blood pressure and also retain sodium in the renal tubules. When sodium is retained, along with the sodium, a lot of water is retained, which brings back the extracellular fluid volume or effective circulating volume to a normal level to a set point. Now how it works, let us see. So here in this graphic, we are seeing that whenever there is a reduction in effective circulating volume, it is sensed by these sensors. One of the sensors are present in afferent renal arterioles, other sensors are present in arch of aorta, carotid sinus, pulmonary circulation, and the fourth are the atria. When the effective circulating volume is reduced, the renal afferent arterioles are activated, which cause the release of renin. Renin causes conversion and production of angiotensin II and also aldosterone. These are the two hormones which cause potent vasoconstriction and also retention of sodium in the renal tubules. So when there is a potent vasoconstriction, it increases the blood pressure, and when there is sodium retention, it retains the water from the kidneys, preventing diuresis or loss of water in the urine. So water is preserved, and at the same time there is vasoconstriction. Both these mechanisms, they improve the extracellular effective circulating volume. So this is one pathway. The other pathway is activated by these sensors, the aortic arch of aorta and carotid sinus. When these are activated, they activate two pathways. One pathway is they cause increased discharge from vasomotor center. The increased discharge from the vasomotor center causes increased sympathetic activation. Whenever there is increase in sympathetic activation, it also causes vasoconstriction and a lot of sodium retention in renal tubules. The third mechanism is the release of arginine vasopressin. When the blood pressure falls to very low level, arginine vasopressin acts on V1 receptor and causes vasoconstriction. It also causes retention of water from distal part of renal tubules, as I have discussed earlier. The fourth mechanism is by activation of atrial sensors of effective circulating volume. Basically what happens is whenever there is increased stretch on atria, atrial natriuretic peptide is released. Atrial natriuretic peptide causes increased excretion of sodium and water from the kidneys. Hence it is called as natriuretic peptide, as it causes natriuresis. But when there is decrease in effective circulating volume, what happens is the stretch on atria reduces, which causes reduced amount of release of atrial natriuretic peptide, which reduces the amount of sodium lost in urine. That is, the natriuresis is reduced, and that's how the sodium is retained, water is retained, and effective circulating volume is brought back to a normal level. So these are the four mechanisms by which the extracellular fluid volume is defended. Next, coming to the abnormalities. Abnormalities are dehydration or overhydration. This is a diarodynamic diagram here, which is depicted on y-axis is the osmolality and x-axis is the volume. In diagram A, there is isoosmotic overhydration, isoosmotic volume expansion. You can see here both ECF and ICF are increased. The volume is increased. In the diagram B, there is isoosmotic shrinkage or contraction, in which both mainly the ECF is shrinked, reduced. Example for isoosmotic contraction is diarrhea, vomiting, burns, blood loss. Now let us see the diagram C. Diagram C is an example of overhydration, in which there is hyperosmotic volume expansion. You can clearly see here that osmolality of both ICF and ECF has increased. ICF and ECF has increased. Now in diagram D, we can see here there is contraction of volume, but there is hyperosmotic volume contraction. The volume of ECF and ICF has reduced, whereas the osmolality of both ICF and ECF has increased. Example of this is uh, over enthusiastic treatment with hypertonic solutions like 3% normal saline. Now, the after D, if you see the E, in E we can see it is volume expansion. It is hypoosmotic volume expansion, which is seen in syndrome of inappropriate ADH secretion. Here you can see that both ICF and ECF has increased, but there is reduction in osmolality. F diagram shows the example of hypoosmotic volume contraction. Now, let us also learn about effects of adding common IV fluids. So again, this is a Darrow-Yannet diagram with y-axis showing osmolality and x-axis showing the volume. The pink area shows intracellular fluid and yellow area shows extracellular fluid. When isotonic normal saline is added, only there is volume expansion of ECF, extracellular fluid. And when hypotonic solution is added, example of hypotonic solution is 0.45% normal saline. What is happening? There is increase in osmolality of both ICF and there is decrease in osmolality of both ICF and ECF, but there is increase in volume of both ICF and ECF. Now, when we are adding hypertonic solutions, example of hypertonic solutions, yes, 3% normal saline. When we add that, you can see that there is a increase in osmolality of ICF and ECF. At the same time, there is shrinkage of ICF, intracellular fluid, whereas there is expansion of extracellular fluid. So when we add hypertonic solution, extracellular fluid is increased at the expense of water, water extracted from intracellular fluid. That's all, folks, about total body fluid compartments. And if you have any doubts, please put it in the comment section. And also you can get to me in Telegram. I'll be giving you assignment. Please answer it. Thank you.